I'm Rachel Marsden. I'm a service and system designer at the Helix Centre in London. I joined there a few months ago. Prior to that, I was working for the design studio Fjord in the Dock in Dublin, which is Accenture's Global Innovation Centre. So this is kind of a new step for me to be more sort of specifically in the world of healthcare, but it's been a fantastic move. So I'm going to start today initially just giving you an overview of Helix Centre, so who we are, what we do, the type of work that we're involved in, and then I'll go into a case study sort of more specifically about a piece of work that I've been involved in here. So first of all, just to give you some context as to where Helix sits. So it's within Imperial College London, and then within that, the Institute of Global Health Innovation, so IGHI. IGHI is one of Imperial College London's Global Challenge Institutes. So established in 2010, and its mission is really to improve global health, health and care through evidence-based innovation and to reduce inequalities in global health. So it's led by Professor Lord Aradarzi and Dr. David Nabarro, and it leads this cutting edge research across, it's sort of structured across 4 centres of excellence. So we have the Centre for Health Policy, the Helix Centre, the Hamlin Centre for Robotic Surgery, and the Centre for Digestive and Gut Health. So the work that in the IGHI, it sort of spans medicine, policy, technology, and design. So as I mentioned, I'm from Helix Centre, so that's what I'll be speaking about. Worth mentioning as well that IGHI also offers several education programs at Imperial College. So those include master's degrees in patient safety and health policy, healthcare and design, and medical robotics and image-guided intervention. So a number of people from our design studio at Helix, they actually will teach on these programs as well. So in terms of Helix Centre, it's a joint collaboration between Imperial College London and the Royal College of Art. And then it's actually located within St Mary's Hospital in Kensington in London. So what we have then, it's sort of built on this legacy of collaboration between the 2 institutions. So we have the Royal College of Art, the RCA, which is a postgraduate art and design college, so bringing design and digital expertise. Then we have the Imperial College itself. So that's the sort of, as we see at the epicenter of medicine, science, engineering. So they're bringing this kind of clinical, academic and engineering expertise. And then that location within an NHS hospital kind of gives that unparalleled access to patients, to public and to frontline staff. So this all sort of feeds into our identity at Helix Centre. So we see ourselves as an innovation lab working at the heart of healthcare with a mission to translate research into products and services that improve health outcomes. So we're a relatively small team of designers, sort of around 20 people, but it's not just designers. We have technologists, clinicians, and researchers. As I said, I've joined relatively recently, but in general, they've worked with thousands of different patients, professionals to develop solutions for some of the most important challenges that we face in healthcare. So I guess we're sort of seeing daily that design can engage people. We're sort of, as technology is something that can really enable change, but design being the thing that really engages and get to the heart of those kind of human needs and motivations. So we have a kind of range of focus areas. So early detection and screening. So this helps sort of increase the chances of receiving the best treatment at the right time and improves the efficiency of the health system generally. Then we have effective treatment. So that's made possible when healthcare professionals can access the best practice, guidance and support and have that sort of at their fingertips. And then holistic care is a really big part of the work that we do at Helix. So whether that's supporting people to live well with dementia, we have a team sort of who are situated within the Dementia Research Institute. We also have a team looking at how to help people make fuller recoveries from stroke, and then a big focus area as well around receiving end-of-life care and making sure that people have the kind of end-of-life experience that they would wish. And then the final piece is around digital transformation. So that's where I'm more kind of located. So thinking about how we can create joined up services within a healthcare system that's made up of so many different providers, legacy systems, lack of interoperability, and so on and so forth. Recently, someone sort of described the NHS to me as if you think about seeing a massive whale, and that's what it looks like from a distance, but then the closer you get, you realize it's actually a shoal of fish. And they're all swimming in the same direction, but they all have their own sort of different thoughts and different ways of doing things. And so it's that sort of, how do you work with such a massive system and try and kind of, as I said, create that interoperability and so on. So in terms of those are the focus areas, within that we have areas of specific expertise at Helix. So as I mentioned already, end-of-life care, patient safety, neurorehabilitation, dementia care, mental health that I'll look at a little later in the presentation, clinical decision support, and cybersecurity. And then these areas of expertise are sort of cross-cut by a range of specific disciplines. So as I mentioned, we have members of the studio who are involved in education as well, data science, PPIE, which is patient public involvement and engagement. Design, obviously, we have a big kind of design presence at Helix, economics, and then trials and evaluations. So in terms of the type of work we do, it's across various settings. So within hospitals, within community care, and then sort of care in the home itself. So in hospital settings, we're looking at things like clinical task management or pediatric emergency dosing. In terms of community care, Helix were involved in creating the Respect form, which has been implemented in the NHS and has been hugely successful. Also looking at sort of cell-free biosensors, prototyping, and then at home, I've already mentioned that we have this team working around stroke rehabilitation. So they're looking at sort of how to use smart devices to help monitor that, that recovery, and also digital care planning live. So you can see that a lot of the work we do has been quite product orientated. So whether that's a sort of a form, an app, a smart device. So actually something I'm going to do in this presentation is sort of look at the sort of other side of things, which is where you don't, is how do you even get to that starting point to start thinking about what a solution might be. But we'll get there in good time. So while these focus areas and outputs are relatively diverse, all the work we do is unified by one key thing, and that is about keeping people at the center of everything that we do. So our goal is really across all projects tends to be to develop empathy with sort of small but varied groups of people. And so that involves observing, shadowing, interviewing, whether that's one-to-one sessions or maybe groups or sort of focus groups, really just to try and get to the root of people's needs and motivations. The best place we find to develop this empathy is in the environment in which people sort of either live, work, play. However, all the research that I've been involved in since joining Helix has been in the shadow of the pandemic. So everything has been conducted online. So obviously we're then having to sort of develop new ways to gather insights. And I feel there's definitely, despite us being almost 2 years into the pandemic, there's still a lot of work to be done in this space. So instead of the sort of in-person workshops that you see here, or shadowing or in situ interviews at home, in sort of in clinical settings in hospitals, we're spending a lot of time on Miro. I'm not sure if everyone's familiar with that sort of online whiteboard tool. You might know it as Mural. Also just conducting interviews on Zoom, Skype, Teams, Google, every platform known to man. So what we're really finding is that the need for storytelling and the need for sort of great facilitation becomes more necessary than ever. We have also found, though, of course, it has its benefits conducting research online. You manage to speak to some people you wouldn't necessarily always be able to access. We've also had projects where we've been speaking to people about virtual consultation, for example, and their experience of having virtual consultations with GPs. And we're conducting that interview almost as a virtual consultation. So it sort of becomes a prototype in itself. So there are a lot of benefits as well. The design process that we take at Helix pretty much always involves creating prototypes, which, you know, it's about creating something as quickly as possible and as early on to test ideas to get feedback from the people who are going to use them. And this is always the approach, all the kind of products that I showed you earlier. This is the approach that would have been taken. But as I mentioned, even though this is often the most interesting and the most exciting part of the design process, certainly the most sort of aesthetically exciting, I wanted today to talk about something kind of a little bit different. Instead, look at some of the really knotty, complex questions that we have to dissect, or what could be called wicked problems, and really just think about how do you sometimes get from that big question to a starting point where then you can start creating a brief and start thinking about moving into creating some of these prototypes to test. So the type of questions that we're working with, for example, like how can we support procurement and implementation of virtual consultation platforms? So this is a piece of work that we did last year. So kind of building on the momentum of being in a pandemic where a lot of consultations had gone online. How can we build on that momentum and improve that service? But thinking about it when all providers are using different systems and we need service users to feel like it's all part of one universal experience. So that's sort of an example of a piece of work that we looked at. Something we're working on currently is how to create truly personalized care plans in care homes. Some of the challenges we're already facing is what if everyone has a different definition of what a personalized care plan is? So before we even start thinking about creating something, so whether it's a digital tool or a new form or whatever that might look like, something that's quite tangible, what we need first is a shared language or a shared vision for what a care plan even is. And the piece that I was going to focus on now, just as a sort of case study, is a piece of work that we were involved in at the end of last year. And so the question was, how can we create seamless mental health experiences across multiple services and providers? So with these types of questions, as I said, sometimes the most challenging thing is figuring out where do you even start? And it's really tempting to jump in and just create a new product that you think is going to solve this situation in one go. But that's where this sort of systemic approach comes in, of needing to take that step back and sort of zoom, if we think about the kind of macro and micro, so zooming out to that macro view to try and understand what the different relationships are, and then make a more strategic decision about where's the most impactful place to actually start. So if we shift gears into this case study, so this was a collaboration between Sussex Health and Care Partnership and the Helix Centre. As I said, this was sort of towards the end of last year. The objective of the project was this sort of North Star vision, I suppose, was keeping service users and carers at the heart, provide a mental health system that is experienced as seamless, easy to access, navigate, and move in and out of as needed. So that's a pretty lofty goal when you think about that mental health in this specific region is provided by multiple different providers, all kind of various levels, varying amounts of funding, all using different systems that are not necessarily interoperable. And as I said, that long-term vision is that people should be able to access support from no matter which provider or multiple providers at the same time, but this experience should feel really seamless and it should all feel as if it's one single service. So this was a sort of discovery period, I suppose we'd call it in design. So just a 14-week project. And we brought together a diverse group of stakeholders. So we had our sort of design team, we had service providers, charitable organizations, and we also had what we call experts by experience. So these are people who would have gone through the mental health system in some form or other, and maybe they still are accessing services, but they're in a position that they feel that they want to actually help improve the services, and they're sort of offering their time for research projects such as ours. So the goals for this phase of the project, and I think really key to point out that this is one phase of a much longer, obviously at some point we would be getting to some sort of physical tangible output, but I'm really just talking about this initial kind of scoping phase to just show, as I said, how can you get to some specific focus points from what initially feels like a pretty complex, messy state. So the project, the sort of goals for this specific phase were just to understand the current state. So what are the existing services? How do they link together? Where are the dependencies? Which tools are they using? Who are the key actors? Then these look equally weighted, but I would say from our sort of team perspective, this central piece around user provider perspective, that's like a huge kind of chunk of what we were doing, was really understanding how people interact with the existing services. What are their frustrations, their positive experiences, their hopes for the future? And then linking all this together to start forming some form of future strategy. So identifying those opportunity areas to test early stage concepts or non-working prototypes. So in terms of who we spoke to, this is a qualitative approach. So not a huge number. This is from the service user perspective. So people who were accessing mental health services. So we had 11 in-depth interviews, so they'd be about an hour long each. That was a mix of people who are currently still using mental health services and those who've been discharged, and in sort of ages from 25 to 64. The type of things that we were asking was really just trying to initially understand what is their experience. So any previous experience that they've had, from which teams, and just generally what is their journey through the system. Part of that obviously is that initial point of how do you access services, and what the continued support might look like. What's the difference between self-presenting versus referral and so on. Also, a key thing is understanding their needs and frustrations. So what they love, what they would change about the care that they've received. We've also been asking, just trying to understand the pandemic perspective. So what are the pros and cons of online experiences? And actually from a mental health perspective, that was kind of very interesting for a lot of people. It was this massive relief to be able to have consultations and to access therapy online from the safety and comfort of their own homes. We were also wanting to understand alternative services. So what's the role of non-NHS services? What's the role of friends, of social prescribing, etc. And then finally, hopes and fears. So starting to move to that visioning statement that would then sort of help us later on understand what can we maybe start prototyping, or what sort of solutions might we look at? So what is the ideal experience? We were very keen to have both sides of the coin. So we spoke to, yes, service users, but obviously we also wanted to speak to service providers. So a few more, 16 interviews in this case. And they were split between SPFT, so that's the Foundation Trust in Sussex, but also looking at voluntary community and social enterprises as well. So you can see some of those sort of listed below. And again, we're asking similar questions, a little bit of variance. So from a service provider perspective, we want to know what's their role, how they're kind of the key challenges that they have, how they collaborate with other teams, their needs and frustrations similar to service users. Again, the pandemic perspective, system navigation is a huge thing. So just understanding if you refer someone, how do you track that referral? How do you perceive that service users navigate the system? And then again, that piece around hopes and fears. I think with any piece of work like this, it's really crucial to acknowledge the gaps and limitations, of which there pretty much always are some. So for us, whether it's hard to reach service users, whether it's around maybe our sample not being diverse enough. For example, a piece of work we're doing at the moment in care homes, trying to access care home residents in winter in the middle of a pandemic is probably sort of the worst time to try and access those users. But then we have to start thinking about how could we use proxy users, or how can we find work that's already being conducted that would help support our research, or how can we think about changing that access? So for example, going to the care home matron meetings that always happen once a week, how can we go to those and turn that into a workshop instead, so we're not kind of adding additional burdens to people's work? But I think with this work, yeah, one of the key things for us was realizing that while we had those experts by experience that we were speaking to and the service users, everyone we spoke to, by nature of us being able to access them, were people who had access to services. Whereas actually we didn't manage to speak to anyone who hasn't managed to access services. And in theory, they could potentially be the most vulnerable people. And so we hadn't consulted them. So I think it's about acknowledging the gaps and then thinking about what can we do to address that in the next phase. So in terms of the research itself, just to kind of behind the scenes for anyone in design, I'm sure this is a very familiar site, especially over the past 2 years. What would have once been a wall is now a kind of whiteboard online. but it's just about gathering all that information. So every color here represents a different individual that we've spoken to. And then when we think about starting to try and synthesize that information down, so our way of navigating the information is sort of teasing out pain points and root causes. And again, that's a key thing around sort of a systems approach. I'm sure everyone probably has a slightly different definition when they say systems design. When I'm speaking about it, I mean it in probably a sort of slightly more fluid way. But as I said, again, that point about kind of the thinking about the macro and the micro. So pain points, we're thinking about the day-to-day irritations or frustrations of service users and service providers. And then the macro is those root causes. So what when we zoom out, what are those actually all kind of combining together to create? And those tend to be sort of broader systemic issues that can be really hard to change, like culture or communication or data access. So the goal is to try and address the root causes, and you'll solve for multiple pain points. But the key thing, and that's kind of the point of what I'm trying to show here, is it's about understanding and identifying those root causes first and figuring out where can you even start. You won't be able to read this. Sorry, it's just a bit kind of visually zoomed out to show you that then through that synthesis, what we sort of ended up with was these six key themes, which I'll kind of go through and I'll bring you into a little bit of detail in a minute. But this way of organizing the information helps to make it feel a little bit tangible. And as I said, starts to help identify where we might kind of make a start. So when I mentioned before those pain points, so what we have here, so you'll see the sort of, this is a key theme, and then it filters down into these pain points. And each one will have a specific category. So for example, if we have diagnosis bias, that is a pain point category that we've heard. And then we have the specific pain points that are related to the service user, but we also want to see the other side of it, which is the service provider, because then we can start seeing, is there a link here? Is there a disconnect? Is there something that service providers are doing that we could change, which would automatically address the pain point from the service user side, for example? And then what we do is we translate all of these into these how might we questions. And again, anyone in design on the call will be very familiar with that format. When we say how might we, it's just a way of asking a very open-ended question, but what it is it's the starting point of creating a design brief that then we can sort of focus in on again and start conducting some more specific research. And this, again, and I apologize that you won't be able to read this because it's very zoomed out, but just another way of viewing this is to see how one root cause is connected to multiple pain points. So we have on the left, these are all the root causes that we've identified. As I said, those big systemic issues like communication, training and expertise, available data. Here we have all those sort of day-to-day irritations like waiting or the use of deficit language or diagnosis bias, for example. But you can see how one root cause like communication feeds into multiple different pain points. What we can do then is we can start saying, well, where do we want to start? We've got a sort of, initially we were saying, how can we create seamless mental health experiences? What we've now moved to is some form of a map in a way to show, in order to create seamless mental health experiences, we have to address all of these things. And one app, one form will not do all of that. So where do we start? And for example, our team identified through us sort of speaking with service users, providers, and bringing in our subject matter experts and multidisciplinary team, identified that actually the experience of waiting to access services, that was a massive issue and sort of in a way felt like the most urgent thing to address. So then we say, okay, well, we'll start there, but through that, and I won't go through all the stages of that design process, but, you know, just starting to kind of conduct more specific research, start prototyping some potential solutions, we can see that by addressing the waiting experience, we'll actually start hitting off some of these other pain points as well, like continuous support or capacity and resource. So as I said, this kind of just helps to make what our initial 1 hour long conversations into something that feels a bit more tangible, and we can actually start sort of moving our way through and making some strategic decisions about where to first sort of take action. And yeah, that's just a zoom in to sort of show you so the types of pain points that are coming out and how they're grouped into these key themes. So I know a lot of these slides you can't read, so I just wanted to go into a little bit of detail to show you what the type of things that are coming out of the research at this stage. So as I said, we've identified these 6 key themes. So if we zoom in on those to look at, this is the type of thing that was coming out. So we have system culture. So here we're thinking about those ingrained behaviors within healthcare provision that have an impact on user experience and outcome. These themes, just to say, are obviously at quite a high level, that then the detail comes when you start kind of opening them up and looking at the specific pain points and the sort of quotes from users and service providers that sit within them. Accessibility and user centricity, so that ability of the service to be inclusive and focused around the needs of the population that it serves. Human interaction, so that especially, well, I'm sure actually it's relevant across all sectors, but within mental health, that relationship that's built between the service user and the service provider, that sort of therapeutic alliance is absolutely crucial. Then we have system navigation, which when you think back to that sort of zoomed out view of the 6 themes, that was actually the biggest one. It had the most pain points, the most problems from both sides. So that understanding of how, where, why, and when to access different services. So as a service user, from that initial first point of access, but also from a service provider, how to actually communicate with the other services as well, and sort of track someone as they move through the system. We also looked at prevention and maintaining health. So what are the structures that support people in the community that promote well-being? So that more sort of prevention rather than cure approach. And then finally, capacity and resource, which interestingly, well, or maybe it's sort of predictable, nobody on the service user side kind of identified this as an issue, but a lot of the pain points that they were feeling day to day were linked back to the fact that there wasn't enough capacity and resource. Whereas from the service provider side, for a lot of them, that's the very first thing that they say is there's overwhelm at every level, that we're trying to hire the right people, but there aren't enough people being trained to do the things we need and so on. So as I said, sometimes you can make that kind of direct connection between the 2 different viewpoints. And I won't go into sort of much more detail. I've only got a couple of minutes left, but as I said, we sort of, if you started to unpack some of those themes, we're thinking about like, how are they manifest? Why are they important? So here within system culture, one of the kind of pain point categories we're looking at is diagnosis bias. So from a service user perspective, the pain point is that it acts as a barrier to accessing the services that they need. From the service provider perspective, it's that they're not having necessarily they have a lack of expertise or knowledge at the point of diagnosis. And it's very easy once these things have been synthesized down and down and down into sort of the themes, the pain points, that sometimes you can start feeling that you've lost touch with the person who was actually at the center of these. So what we've made sure to do throughout the research is always connect everything back to some key quotes that have come from the people that we spoke to. So from a service user, for example, once I was diagnosed with autism, they saw me as a human again, as opposed to being seen as manipulative. And this was seen specifically around misdiagnosis of personality disorder, which for us, when we spoke to the service user, it felt like quite a specific, isolated event. Then when we spoke to service providers, we have this quote that women are being diagnosed with emotionally unstable personality disorder instead of autism. It's really so shocking, and it happens a lot. And slowly this started to become a theme in itself, that this sort of gender inequality around diagnosis. So what I'm trying to sort of demonstrate here, I suppose, is just to go back, this slide probably is the easiest way to illustrate it. As I said, is how do you get from a really big question to actually turning it into something tangible and identifying a starting point? Obviously, the danger with that is as soon as you start unpacking that thing itself. So as I said, just there, that piece around gender inequality and diagnosis, that feels like a whole other set of research, which would be incredibly interesting and worthwhile to do. So we do this as a way to kind of get to that brief and that starting point. And now we have a brief around addressing the waiting times to access mental health services. And that's a really tangible thing that we can now start doing and move towards some of those sort of product solutions that I showed you earlier on. But through doing this, we've probably developed multiple other briefs that will have to wait their turn, but will be incredibly interesting to look into at a later date. So that's me on 30 minutes.